Emma's going to be reporting on some extraordinary results on in utero enzyme replacement therapy. This is a treatment that has been pioneered by a visionary interventional in utero gene or in utero fetal surgeon named Tippy McKenzie. And she has initiated a trial to treat children for multiple gene therapies or multiple lysosomal storage diseases. Let's see here. Getting to the right drive. God bless Bill Gates.
Thank you very much.
Take it away, Emma. Thank you. Forgive the delay.
You. Oh, no, you're okay. Thank you, Matthew. So hi, everyone. I'm Emma Canepa, and I am the program manager for clinical trials at UCSF, working very closely with Dr. Tippy McKenzie, who is the PI of our phase 1 clinical trial for prenatal enzyme replacement therapy for MPS and lysosomal storage disorders. So first, we always like to start off with why prenatal therapy. So as I know, I don't have to tell any of you, a lot of these more serious early onset forms of these conditions often present before birth or very soon after birth. And so what we're hoping to do and to see with prenatal administration is we're really hoping to prevent the in utero demise that can sometimes occur from the more severe forms of these conditions, and again, prevent some of the organ damage that can sometimes occur. And we're also hoping to deliver some of the enzyme into the brain for as long as we can. I know Dr. Munzer just explained the blood-brain barrier and the challenges that we have with getting enzyme into the brain postnatally. But during the prenatal period, the blood-brain barrier is a little bit more permeable. So we're thinking that we'll be able to access the brain and the central nervous system to help protect them for as long as possible until babies can get the postnatal care. We're also hoping to potentially induce tolerance to the missing enzyme. And what we're trying to do here is really take advantage of this unique period in fetal development where the fetus is a little bit more accepting of foreign antigens and the immune system is less reactive. So we're hoping that by introducing these enzymes earlier on during this period, it might help reduce the chances that some of these kiddos will develop anti-drug antibodies to enzyme replacement therapy postnatally. I presented on this slide last year, and I have a lot more patient data to present, so I'm just going to quickly remind everyone that we did try this in MPS 7 mice before we moved into the phase 1 clinical trial, and we found that it worked really well. We showed improved survival as well as tolerance induction and evidence of brain penetration as well. We also performed a survey with patients and caregivers to see what their attitudes towards fetal therapy might be. And overwhelmingly, the responses were really positive, and it seemed like folks were interested in this as a potential option. And I really just want to give a big shout out to the MPS Society. We really couldn't have done this without you and connecting us with all these patients, so we really appreciate it. I really want to mention that this is a multidisciplinary effort. I mean, it takes a whole village to do this, really, of investigators and experts from all around the country, including in fields like maternal-fetal medicine, fetal surgery, and of course, metabolic genetics. We work very closely with Dr. Paul Harmatz, who I know you're all very familiar with, and Dr. Michael Gelb as well. So to give a brief overview of the study, what the study timeline looks like for participation, it often starts with a confirmed diagnosis prenatally, either by amniocentesis or CVS, for any one of our included conditions below. And these include 5 different MPS conditions, including MPS 1, 2, 4A, 6, and 7. And then for maternal-fetal dyads that are eligible and who choose to move forward to participate, they'll receive fetal infusions every 2 to 4 weeks between about the 18 to 35 weeks gestation. And basically, we're not infusing new enzymes. These are the postnatal FDA-approved enzymes that you're all familiar with already, and we are just administering them earlier. And we adjust the dose to based off of the estimated fetal weight from an ultrasound the same week of the next infusion. And during this time, we're really focusing on our primary objectives. This is a phase 1 clinical trial, so those would be safety and feasibility. And then postnatally, our patients continue to receive postnatal enzyme replacement therapy or whatever care is most appropriate for them, depending on what the family decides with their care provider. And we're also very supportive of our families participating in additional clinical trials postnatally if they're eligible. We don't want to preclude any of our patients from taking advantage of other clinical trials that might be available. And during this time, we're continuing to look at secondary objectives. So are we seeing decreased biomarker for MPS? These would be GAG levels. Is there any evidence of tolerance to enzyme replacement therapy? And then we're continuing to look at long-term outcomes. We are following up on all of these patients for 5 years. For families who are interested in participating, we often start off with a Zoom call to discuss the study and start answering questions and explain all of the potential options for the pregnancy. And this stage also might include some education about the disease. I know that everyone here, you're all experts in these conditions, but a lot of families, when they come to us, they may have never even heard of these conditions before. And so we really want to make sure that they have all of the tools at their disposal to make the best informed choice for their family. And we really rely heavily on Dr. Harmatz and the other experts that we work with to help us do this. We also will evaluate eligibility as best as we can ahead of time. One thing that is a requirement for the study and really important to us is to make sure that the maternal-fetal dyads that are being enrolled, that the fetuses are affected by an early onset form of the condition. Obviously, we don't want anyone who wouldn't necessarily benefit from this early intervention to have to take on those risks of the prenatal intervention. So that's something that we work with an enrollment advisory board to go through what the family history is and what the specific genotypes are to make sure that we're very careful about that. And then, of course, families will come to UCSF for screening and potential enrollment in treatment. And then the study pays for all medical and travel or relocation costs associated with that. So this is what the procedure looks like. Under ultrasound guidance, a small needle is inserted into mom's abdomen and into the umbilical vein for direct access to the fetal circulation. And I've gone over what some of the potential benefits we're hoping to see are, but there are some potential risks that I'd like to highlight. Anytime we poke that umbilical vein, there is a really small risk of preterm delivery, which can be really concerning if this happens earlier on in gestation. It's a very small risk, especially in the experienced and talented hands of our proceduralist, Dr. Gonzalez, but of course it's a really important thing for families to consider. And then just like any other surgical procedure, there are small risks of bleeding or infection. And then there's also a theoretical risk of allergic reaction. We don't really expect to see this, but anytime you're administering a medication to someone, this is something that you have to be prepared to address. And then there's just a picture of our team all suited up after one of our prenatal infusions. One thing we're really proud of is our recruitment efforts and the outcomes of these recruitment efforts. As you can see, when we first opened for the first couple of years, our referral numbers were pretty dismal and pretty low. As I'm sure you're all familiar, it can be really challenging to recruit for these clinical trials. And especially, I feel like I always say we're looking for a needle within a haystack with our specific patient population. But as you can see, we've really ramped up. And this year alone, this says that we've enrolled or received 17 referrals this year. Since I submitted these slides, we've actually received one more. So we're now up to 18 for 2024, which is really incredible. And again, just huge shout out to the MPS Society. Leslie, I don't know if you're in here, but she's connected us with so many families, and we really couldn't do this without the support of patient groups. So just to remind everyone, our first case of in utero ERT was with a fetus with infantile onset Pompe disease. And this case was actually published in the New England Journal of Medicine, and you can also read about it in the New York Times. But this was this family's fourth affected pregnancy with IOPD, which is a related lysosomal storage disease to MPS. And they had two older children who both passed away from the condition at 29 and 8 months. And, I mentioned earlier something that we consider for eligibility is the timing of likely disease manifestation and then how severe this phenotype is going to be. So we knew this family had a severe phenotype. There was evidence from the older siblings that they experienced really early onset cardiomyopathy, which is a thickening of the heart muscles that can happen with IOPD patients. So we went ahead, and this family was appropriate for enrollment. And they received 6 doses of in utero ERT. The baby delivered at term, and she's now over 3 years old. And there's a picture of her from about 1.5 years ago. And she's continuing to have normal cardiac function, normal motor function, and is hitting all of her developmental milestones. And then here, I mentioned that heart thickening that can happen with these patients. So here are just some images from prenatal echoes that were done. On the top, those images are from her older sibling, and you can see where the asterisks are, how thick that space is in between the two dark spots, which are the ventricles of the heart. And so that's indicative of pretty severe cardiac hypertrophy and illness. You compare that to her images there on the bottom, and that space is much thinner and much closer to what you'd expect to see in a healthy heart. And all these images were taken around 34 weeks gestation for both patients, or for both individuals. Our next case was a patient with MPS 2. And this family has a history of, they're very severely affected. They are affected with a form of MPS 2 that produces essentially no residual enzyme. And they received 5 prenatal infusions, and this baby was born at term. Safety-wise, we continue to see no anti-drug antibody development. This baby just finished his 2-year follow-up, and there were no pregnancy complications. And then efficacy-wise, we saw a really nice decline of GAG levels during the in utero treatment. And at birth, we actually looked at, in collaboration with Dr. Michael Gelb, we looked at MPS 2 markers on the dried blood spots at birth. And you can see our patient all the way over there on the right in the purple. His levels were well within the normal range compared to untreated newborns, which were, you can see are all above normal range. And then in addition to that, the postnatal GAGs were lower than what you would expect to see in affected untreated babies, and they were normal at birth before the first postnatal enzyme replacement therapy treatment. Next was our patient with MPS 1. There he is at his 1-year follow-up visit. This family had an older child who unfortunately passed away due to complications from bone marrow transplant many years prior. And they're affected by a severe form of Hurler-Schett. They received 3 prenatal infusions, and he was also born at term. Again, we're continuing to see no evidence of anti-drug antibodies, and there were no pregnancy complications. And the efficacy data looked very similar for this patient. So we saw that same decline of GAG levels during the in utero treatment period. The MPS 1 markers, again, were within normal levels at birth. And the postnatal GAGs, while they weren't within normal levels at birth. They were very close, and then they rapidly declined much faster than what you would expect to see in untreated patients. So now we're getting into our new patients from the past year. So this patient had CRIM-positive IOPD, and this family had 2 prior affected children who had early onset disease and are receiving postnatal ERT. They received 5 prenatal infusions, and this baby was born at 36 weeks gestation. So we consider term to be 37 weeks. This baby was born a little bit earlier, but this was the plan that was preferred by mom and by her care team. She did develop gestational diabetes and preeclampsia or high blood pressure during the pregnancy. This was unrelated to study participation. She had a history of developing these conditions in prior pregnancies, so we were looking out for it, and these are things that are not uncommon for people to develop during pregnancy. This was part of the reason why they decided to deliver a little bit earlier. And we saw no anti-drug antibodies. The efficacy data for this patient looked very similar to the first IOPD case. Again, we didn't see any evidence of illness or no abnormal cardiac findings on any of the echoes for this baby, either during or after pregnancy. And that, compared to his older sibling who did have that cardiomyopathy prenatally. And then another thing that we look for in IOPD patients is creatine kinase or CK levels. They tend to get very elevated in these patients. And so you can see both of our treated patients there in the red and in the blue. They were within normal levels at birth compared to untreated newborns, which, as you can see, are well above normal. And then finally, our patient with neuronopathic Gaucher disease. So this family experienced a neonatal loss a couple years ago. For their older child had the same condition, and they actually traveled all the way from Brazil, and they lived in San Francisco for 6 months to participate in this study. So it was really, really incredible. They're such a young couple, and they didn't speak any English, and they were here for quite a long time. So it was really amazing to be able to care for them. They received 6 prenatal infusions, and this baby was born at term at 37 weeks gestation. Again, we saw no anti-drug antibodies, and there were no pregnancy complications. I will note that with neuronopathic Gaucher, we weren't really expecting to see any anti-drug antibodies. This condition, for whatever reason, doesn't typically develop them, but it was still reassuring that we have not seen any yet. He's now 4 months old. And then regarding efficacy, so something that can happen with these patients with neuronopathic Gaucher is they can develop thrombocytopenia from really low platelet levels. And those will show up on a CBC blood test. And that's something that his older sibling experienced. You can see her levels there in black. When she was born, her platelet levels were quite low, and they just continued to drop. You compare that with our treated patient who's there in the blue, and his levels remained normal throughout pregnancy, and then they started to drop right after the final in utero infusion. You can see at that 35-week mark, they started to come down, and they were just around normal at birth, and then they dropped a little bit more, but then they quickly rebounded after the first postnatal treatment. Another thing that's really exciting for us regarding this family is that on the first screening ultrasound, this patient had bilateral adducted thumbs, where essentially the thumbs are kind of held into the palm like this. And you can see what that looks like on the ultrasound there. And this is a sign of the neuronopathic manifestation of his Gaucher disease. And after 3 in utero infusions, this resolved. And on that next ultrasound, he was giving us a thumbs up, which was pretty exciting for us. I do, have to say too, we don't expect this to be a permanent result. Of course, after birth, the blood-brain barrier is closing or has closed, and so we don't expect that he's getting any enzyme into the brain or central nervous system now. But this was a really great proof of concept for us, and it was really encouraging. So in conclusion, we've treated 5 participants so far. We haven't seen any safety concerns, and all of our patients have delivered full term or as planned. And we've seen improved biomarkers in all cases. And we know that this isn't a perfect solution. But we're really hoping that this can act as a bridge towards more definitive therapies, towards improved enzyme replacement therapy that can access the central nervous system, towards gene therapy, or improved bone marrow transplant options. So we're really hoping that this might allow patients to be born as healthy as possible and maintain function, to allow them to get the most benefit from these more curative therapies postnatally. So if anyone here is thinking about expanding your family or knows anyone who is, and this might be something you want to consider, I really encourage you to screen your pregnancy as early as possible. We're happy to speak to you at any point, even before you have a confirmed diagnosis, just to kind of get your thoughts, talk to you about the study. We love hearing from you all. So please don't ever hesitate to reach out. There's my email there. And that QR code will also take you directly to our study website if you want more information. And again, we cover all travel and medical costs for the nuclear family to come to San Francisco for treatment. And we just so appreciate all of your participation and interest, and we couldn't do this without all of you. So thank you.